regarding a molecule we are quite familiar with now. It's been there for about 1.5 years in the market, and that is guselkumab, so marketed as Tramphia. And the company says that start strong and go long. So let's see what they mean by that. To start with, the first objective would be to see the cumulative burden of psoriasis over a patient's life. Now, we all know that psoriasis is a chronic debilitating disease and which has an immense effect on the quality of life of the patient. And we can see it that as the disease starts, right from the diagnosis, the patient might present with few skin lesions, and that might be just only like a stigma to the patient. But it is the disease burden along with which builds up over the years that later on we know 1/3 of the plaque psoriasis patients can have psoriatic arthritis. And then comes the added social problems, and we know that the comorbidities which can be associated are the cardiovascular system, metabolic syndrome, and diabetes. And then comes the psychological damage, and then cardiovascular event is not far. So this is what we need to understand, is that the damage is cumulative because the burden is cumulative. So that means it's better to catch the disease when it is in the beginning to prevent the cumulative damage. And regarding the pathogenesis, so one of the important mediators is the interleukin 23. It is important in many autoimmune diseases like psoriasis, and it is sometimes called as a master regulator. So here we can see that interleukin 23 comes into picture much earlier when the dendritic cells, Langerhans cells, monocytes or macrophages, they secrete it, and later on the T helper 17 cells, they secrete the IL-17, which comes a little later in the picture. So that is what we see clinically later what is manifested as clinical plaque psoriasis or psoriatic arthritis. And if this interleukin is built up in the gut, it will give rise to IBD. So this we can understand by the beautiful stream, downstream, which is being shown here. And I like to compare this like, if a tap, it gets defected and the tap is flowing, water is flowing. So what you will do? You will focus on draining the water, or you will focus on repairing the tap. So if you repair the tap, it is like using IL-23 inhibitor. If you drain the water, it is like using IL-17 inhibitor. And coming to, next slide, it's not going. Okay, so now when we want to understand this disease and treat the patient, we need to see what is the definition. And here we have this international Delphi consensus giving us a beautiful definition of the disease modification, which is a sustained improvement in the disease course of plaque psoriasis resulting from a change in pathophysiology that minimizes the need of treatment. So two things are important here. The focus should be on controlling the pathophysiology, and which should later on lead to minimize the need of the treatment. And they have a beautiful study to share with us, because we, people of science, we want clinical data before we go ahead with the treatment. And here is a beautiful study called GUIDE study by Janssen, which has 880 patients. And it went on for about good number of 220 weeks. And it has 3 parts to it. Part 1 was when the patients were given the loading dose at 0 and 4 weeks, 100 milligrams, and every 8 weeks they were continued till 28 weeks. Then the second part was when the patients were from 8 weeks, they were continued to every 18 weeks. And the third part was when the medicine was completely withdrawn. So this would help us to see how the patients behave during this. And it was done in 85 centers over France and Germany. And this is how it was, that in part 1, it is the loading dose followed by every 8 weekly dosing, followed by at week 20 and 28, when the patients had PASI less than almost 0 or less than 3, then they would be converted into two groups. That one would be continued on every 8 weekly dosing, and the other which would be continued every 16 weekly dosing. And all the patients, so by week 68, all the patients who had received PASI 3 were discontinued the treatment till week 220. And what were the interesting results? It's not moving ahead. Okay, so here what we can see is that what we found out of this interesting study was that there were some patients who responded by week 20. So in such a short time, these were called super responders. So what were those super responders? They found out that the patients who had either they had a short disease duration, the ones who had a short disease duration less than 2 years, and they were not non-obese, or their age was less, were super responders. So that means these factors would actually make the psoriasis severe in patients with these kind of factors were there. But the female gender or the baseline PASI did not influence the results in such cases. So we see that very important factor was if you start the treatment early in the disease, you get a good response. Another modifying in the pathophysiology is concerned, important modifying factor was the control on the T resident memory cells. And here it is seen, it's a beautiful slide showing this is in the non-lesional area where this is the level of the TRM cells. Well, it was high in the lesional area. But at the end of week 68, the lesional was same as the non-lesional. So what do we call this? This is the real disease modification. And what was found, the difference between the super responders and the normal responders was that almost double the number of days were required for normal responders, and almost double the skin clear, double number of patients had complete PASI clearance in the super responders, and the quality of life was about 20% better off in the super responders. There was interesting finding that whether the dosing was every 8 week or every 16 week, the results did not vary much, because you see in both the dosing, the curves have been almost similar. And what was important finding here was that the patients who had a short disease duration, when the drug was stopped, they were treatment-free for more number, 165 days longer they were disease-free. That's almost about half a year. So that means early starting the medicine, early starting the treatment, early intervention in the disease definitely modifies the disease course, because it controls the inflammatory burden in the patient. And when the patient was off the treatment and when they were restarted, it was found that PASI less than 1 was achieved in 43% of the patients within 8 weeks. That means just one dose was given. And second, at the end of 3 doses, that is 24 weeks, almost 80% had achieved PASI less than 1. So that means retreatment was also successful with guselkumab. So this is an important findings in the study, that there was disease modification by targeting the pathophysiology. That means the TRM cells were definitely reduced, and the need of the treatment was minimized, as we see in this patient, this study, that 398 days treatment-free patients with short duration were found to, in this study they were found. Now coming to what is different in Triumpha is they have compared it with the other IL-23 inhibitors in the market, and risankizumab is different in structure because while Triumpha is a completely fully human antibody, but risankizumab is partly murine protein sequence substituted. So when there is heterogeneity in the molecule, what it is going to lead to anti-drug antibodies. And this was far more higher in risankizumab, where it was 4 times higher than the ones in guselkumab. So when there are more anti-drug antibodies, what does it lead to is decrease in efficacy. So this is how guselkumab plays better off. And this is again a little bit more depth into the structure. So while this here, it is the native type, while here it is the LALA muted murine protein substituted over here. So, and another thing is this does not only act on the IL-23 circulating, but it also inhibits the CD64 cells which are secreting the IL-23. So this is why this is a double-edged sword where it acts by dual mechanism. The IL-23 inhibition is done by guselkumab. Now here we can see that in comparison to risankizumab, while initially the response is same, but there's a dip in the risankizumab curve where that means some patients do show mild relapse in the disease. And once the complete clearance in comparison to all the important molecules, if we see, Triumpha is doing better at 84%, followed by risankizumab and secukinumab. Another point we need to emphasize is that guselkumab does better even from risankizumab as well as the radiographic damage is concerned. So where radiographic damage could not be controlled by risankizumab. And now coming to the, when as dermatologists, we know that the molecule is efficacious. The other thing we want to know is about the side effect profile. So this has a good safety data, as there were no active cases of tuberculosis or opportunistic infection were reported, and there were no anaphylactic or serum sickness-like reactions, and there was no case of IBD, as we can find in secukinumab. Now, in my practice, I have come about patients of psoriasis who do have history of some kind of malignancy, because we know that even malignancy, that is also immune-mediated when there is decreased chemosurveillance or some changes in the immune pathway, which also promotes malignancy. So in this where immune-mediated condition, so psoriasis can be a very, found in these patients as well. So we want a safe molecule which can be used even with patients with a history of malignancy. And this molecule is quite safe for patients with a prior history of any kind of malignancy. And these are all the latest molecules which we are using in our practice, and with the guselkumab at single-digit number. So this is the dosing for this drug. In comparison to others, it is much less. And less dosing means less cost involved. And so this also is a very important factor, especially for where we are involved with the insurance cases and all that. So this is an important molecule. So with so many factors, as we learn about this molecule, we can definitely, in my practice, I have found it to be very helpful in my cases, and with a good safety profile. And so that is why I think with the target on the pathophysiology and decrease in the treatment later on, minimizing the treatment later on, definitely this molecule, when started strong, can go long in the treatment of psoriasis. That brings me to end of my talk. Thank you for patient listening.